Colleagues, welcome. It's a pleasure to have another opportunity to work with you all to improve our understanding of primary care. Primary care is one of those very, very unique parts of the NHS that's close to many of our hearts. In many cases, it's the first point of contact for those of us seeking help. As a dad, I want to be able to access my GP when my daughter is unwell, not 6 weeks later, as happens in secondary care. And that's the case for many of us. And that is why primary care is so close to our hearts. I'm Venkataram. I'm an executive director at East London Foundation Trust, and I manage primary care services there. When East London Foundation Trust stepped into the arena of primary care, we had the delight of working with some amazing GPs and nurses who provided fantastic care. We were clear, though, as a large NHS corporate body, we had the resilience. And if we were able to share the resources we had with our primary care colleagues jointly, we could create outstanding outcomes for our local residents. The reason East London Foundation's Trust stepped into primary care was to deliver those outstanding outcomes with the partnerships we have with our GP providers. So, the creation of this webinar series, The Future of Primary Care, is one such initiative in supporting this understanding. And it creates a space for us to discuss the why, the what, and the how of primary care improvement sciences. For those of you who have been with us in this journey for the last 18 months will recognize I always start our webinars with a conversation about the fabulousness of the delivery from primary care over the last month. Last month, I spoke to you about 30 million appointments had been delivered by our amazing primary care colleagues in the month of September. Just when we think they have created this uniqueness, in October, they go on to deliver 36 million appointments. 4 million of those appointments were COVID-related appointments. 44% of the appointments were seen by GPs themselves. About 40% of the appointments were same-day appointments. But importantly, over 70% of the appointments were face-to-face appointments. This fantastic delivery from our primary care colleagues, despite the fact that the workforce in primary care had reduced by 0.9% compared to the same period last year. So that raises the question, what do we jointly do to improve the outcome and the ownership of primary care by the wider primary care workforce? The GPs, the nurses, the paramedics, the pharmacists, the receptionists. One such man who had this amazing vision of creating a very unique ownership model is Dr. Ed Ford. Dr. Ford created the first John Lewis model of ownership, unheard of before he visioned this. As the chair of Somerset Primary Care CCG, as well as the medical director of Minehead GP practice, this vision created by Dr. Ford led to many areas wondering what they could do to improve the retention of primary care workforce. Now, clearly, this drive from an amazing GP like Dr. Ford doesn't come without its own perils. So today, we have the opportunity of hearing from Dr. Ford himself of his journey through the creation of this model of engagement in primary care practices. And we will then have an opportunity to talk to him around how it happened. If I could just remind colleagues, we have over 350 people who have registered for this webinar. Many people have already posted their questions to me, so I will be using those questions as a starter for 10 to initiate the conversation. Ed, welcome to the show. Thank you so much for your time today.
It's a pleasure.
Fabulous. And shall I hand over to you to share your views on how your journey began?
That would be great. And I'll put a few slides together, just more briefing points. But if we could have the first one, that'd be great. So we've been colloquially called the John Lewis model because technically we are what we call an employee-owned trust. So going back to why we wanted to do this, and it was a familiar story to many, many practices where we've got reducing numbers of partners. So we were a GP partnership where we had a number of GP partners who owned and ran the business. But unfortunately, throughout COVID, with recruitment issues, people have been less inclined to be partners and a lot of clinicians just want to get on and do the job at hand rather than actually be running a business. We've got a fantastic and stable team of clinicians and admin staff, and there was a real desire when we were talking about how we develop and evolve was to stay locally owned and run. So to keep the business within the community so that the staff who are part of the community feel that actually the business is community owned and delivered, as opposed to being owned by an organisation that's quite distant to Minehead and doesn't really relate to the particular issues we've got in a seaside town. We've had a great management team and good leadership, and we've always been financially stable as a partnership. So there's no real issues from, the workforce or the finances, but it was just the fact that there were a number of partners who were looking to say, actually, I don't want to be the partner anymore, but I'm quite happy to stay working as a GP. Can we pop on to the next slide, if that's okay? So if we go to the next slide, we'll talk about actually how we engage with the process. So the key thing is with any form of change is engagement. And actually it's not just with the staff, it's with patients, local councillors, key members of the local population to say what we're doing and actually why we're doing it. And it wasn't the fact that we were going to say we're changing our service delivery model, but it's a case of saying we need to actually change our structure so that we have a business that can still deliver the contract. We also obviously needed to engage with the commissioner. And being chair of the CCG, that was a little bit easier. But you still have to acknowledge your conflicts of interest and, say we're doing this as a partnership, we're wanting to move to this employee-owned trust and actually let the primary care team, work without my influence from the commissioning side of things. And it's a two-stage process because what you have to do first of all is you have to set up a limited company. And then once you've got permission from the commissioner to novate the contract from the partnership into the limited company, and you then have to set up an employee-owned trust where the shares for the limited company then move into the trust so that you don't have individual shareholders essentially owning a share. It's quite an expensive process, and obviously being the first was probably more expensive because not just ourselves but also the legal teams were finding their feet. So it does need commissioner financial support if it's going to be viable, but it can be done fairly quickly. I mean, from when the thought first popped into my head, driving back from a meeting to completion was 7 months. So, I think one of the beauties about partnerships and primary care is we can be nimble and fleet of foot. And actually, this just proves that you can do things in a timely fashion. But it is really important to make sure that all the staff are on board. It's, we don't change terms and conditions of their contracts, and they do carry on with the same job that they were doing beforehand, but they are essentially partners in the entire team. And it sort of dawned on me when I was walking around Waitrose Superstore and noticed a name badge, and they refer to themselves as partners, as members of staff. And, this is essentially a partnership whereby all the staff members are equal partners in the business, but without any of the liabilities that go with essentially running a partnership and having to invest money in the business, being responsible for contracts, and actually essentially putting your house on the line if it all goes wrong. So can we go on to the next slide, if that's okay? And I think, one of the beauties about this sort of this model is that it does allow staff to have more understanding as to how the business works, why decisions are being made. Our receptionists now understand the finances of the partnership, and it's quite refreshing as a limited company being able to be completely open and transparent about our finances, whereas previously in a partnership, it's quite opaque. We've had to do an awful lot of budgeting to work on a monthly budget to make sure that we are, we're not overspending and we're living within our means. But everyone from, the receptionist through to the GPs, through to the, the managing director, everyone is engaged in trying to make sure the business operates. And there isn't that disempowerment of staff when they look historically, they were looking to the partners to say, you've got to solve this problem, whether it's financial, whether it's a way of working, whether it's access, because actually everyone in the building is involved in making the business work and doing the best that we can. We don't stop our development and learning. We take a very active approach in sort of quality improvement methodology of constantly trying to sort of improve things. Not everything works, but that's the whole point about, trying to make changes. You learn from what doesn't work and you keep evolving. And I think one of the classic examples of how teams are empowered is that, with cost of living crisis and fuel bills going up, etc., everyone's had to turn around and think, well, how do we save money? And one of our receptionists turned around and said, well, aren't we paying too much for the paper that we get in? I'm sure there's a cheaper version. Went off her own back, sourced paper that was half the price for the photocopiers, the printers, etc. And little things like that would never have happened previously without that sense of empowerment that the staff now have to say, actually, we can influence change and we have got an equal voice. And actually, with the governance structure we've got, the staff have to be listened to because they are the shareholders in the business. So can we move on to the next slide, if that's okay? And I think the governance structure that we've got, we have a management team that essentially get on with the day-to-day running, but then we have trustees who are members of staff who are voted into post by all the staff, and they essentially are like non-executives where they hold the executive team to account. And the key bit that we learned throughout the process is that as an employee-owned trust, you have to work in the best interests of your staff. That is the underlying principle of it all. We have included patients as well, and we have a patient group representative as one of our nominal trustees. They can't be an official trustee because to be an official trustee, you have to be an NHS employee, but we do include them within our governance structure so that it is clear and robust. They can see exactly what income we're getting, where it's being spent, what we're doing to deliver services, and they can influence how we change our service provision. So what have we learned? Well, it's really important to have dynamic decision making because otherwise we'd never have got it done in 7 months. Engaging with the teams, and I think it did take a number of months after we had completed the exercise for the partners to actually allow themselves to step back and allow others to make decisions, but also for the team members to step into that space and go, yes, we can just get on with this. Managing expectations has been interesting. Staff suddenly thinking, oh, we're going to get shares, we're going to get dividends, we're going to get payouts and bonuses and blah, blah, blah. And in the current financial climate, we had to sort of manage that quite hard. But also it's, the key bit was having dedicated management time to do the process, and to manage the process, to manage the staff, to do the HR work, bring people along with you. This isn't something that can just be done on top of the day job. So we did secure some funding to get a project manager in post to manage the whole process for us. CQC were interesting. It's taken us quite a while for them to change the registration because they're not used. We are the first employee-owned trust model. We're not the first limited company though, but it was a challenge to get the CQC to organise the change in registration. And even on a recent CQC visit, there was a difficulty understanding that there weren't partners who we had to go to get permission to do things, that we were just cracking on with it. But the key bit was also financial support from the CCG, or now ICB. You need to make sure that's in writing, it's very clear what you're getting, because one of the critical bits is you can't afford to set up a new company and immediately be in debt to the tunes of tens of thousands of pounds in legal fees. So, if it's going to work, it does need investment. But certainly from a commissioner's perspective, and this is why, as chair of the CCG, I thought this was quite a useful model. You're creating a business in perpetuity that you don't have to worry about succession planning of partners. So it's in everyone's interest to keep that business model going. You're also not creating a massive mega structure of primary care that's, where one organisation is responsible for hundreds of thousands of patients and then becomes too big to fail. But you have got an organisation that can keep on existing as long as it's got staff. Can we move on to the final slide, if that's okay? So this is just the beginning. We've got a few other little things in the pipeline for innovation that we're looking at. And I think one of the key bits about exploring staff and associate grade specialists working in primary care is something that we are keen to look at. Maintaining our core aims and objectives is really critical. As I said, we have to be working in the interests of staff, but also with the interests of patients as well, and also continuing to develop. And I think that's the key bit. We don't want to stand still, because otherwise time will overtake us and events will overtake us. And, we need to be dynamic, but actually having a dedicated management team that now meet weekly and have an effective weekly meeting, as opposed to historically where the partners were meeting at the end of a very long day, not really understanding what was going on and just too exhausted to really be too concerned about how the business was going. But actually we've got, the dedicated management team. So our structures and processes are far more robust and far more tightly run. So I'll stop there. And I think the key bit is to try and answer the questions that people have put forward, because it is new, it is unique, and it does take a bit of time to get your head around it.
Brilliant. Absolutely brilliant. And I think that you can see the interest for this model with over 300 people registering for the webinar. It just shows, and so many questions have already been posted. Clearly, the first one that many people have shared and put across is the understanding that the uniqueness of primary care comes from the strength the team builds in, all the way from the receptionist to the GP at the other end. And it includes the nurses, the pharmacists, healthcare assistants, and everyone who works in that chain. And there is something about recognizing the continuity of care that comes in because local residents sit in those practices and are able to say, this family, I can help them, this is what's needed. So having now put this new model of partnership in the practice, did you find What were the measures you used to get a feel of the strength of primary care coming forward in more force than it was before? Or was it just a feel?
So most of it's a feel, but I think it was about carrying the staff with us on the journey. So before we even approached the commissioner or approached anyone else, we approached the staff to say, is this something that you would buy into? And, you know, there is a certain amount of passivity within, you know, the workforce because a lot of them feel done unto all the time. But actually bit by bit, and then when it actually became reality, I think that's when the penny finally dropped for most people, that actually finally, you know, they can have a say. And it just takes one little thing, like the paper for the photocopiers, where people go, I did that. And then other people then want more of it. And you just see that sort of snowball effect. You know, finances are increasingly tight in primary care post-COVID. We don't have all those sort of lovely sort of COVID payouts that we're having. So people are having to be very, very tight. So there's not a huge amount of money to invest in you know, the business, as it were. But I think it is critical that people are then going, well, actually, if we are going to invest money, are we doing it in the right way? And everyone in the building has got to say, and everyone's, you know, the sort of conversation you have between, you know, myself and the receptionist, we're now having conversations as equals, as opposed to I'm talking to my boss or I'm talking to an employee. And I think that's a really different dynamic. So, you know, the conversations are more honest, they're more open. And I think it is more of a feel rather than being an actual measure. We haven't done staff surveys or anything like that. We've only got 50 something staff, so there's not a huge amount. So we do get a feel for it. I think one of the biggest disappointments, as I mentioned earlier, was about the expectations that, you know, all of a sudden we're going to get, you know, bigger bonuses because you got shares, etc. And I think that's one of the key things that we didn't quite anticipate, how much of a squeeze on funding there was going to be in primary care in the post-COVID era. But, you know, we're not, you know, we're still financially solvent, we're still keeping going, and we're still trying to build up that little bit of equity that we can move forward and people can reap the rewards in the years to come. And I think there is now that understanding that it's a long-term game rather than just a sort of short, quick wins. And that's when people are invested in the practice. I think the other bit that I've been amazed about is having other members of staff that aren't GPs step into leadership roles. So, you know, our safeguarding lead is now one of our nurse practitioners. Our prescribing lead, quite sensibly, is one of our pharmacists. You know, it doesn't have to be a GP doing everything. And they do it better than we do, to be perfectly honest, because they've got more time, they've got more passion, and they're just doing that one focus of leadership rather than having lots of different hats because they just happen to be the partner. You know, our Caldecott Guardian is our IT manager. You know, all those sorts of little things that are just little bits that allow people to spread their wings and lead, essentially, which is what a lot of people really thrive on.
How fascinating. And I think you're spot on when you say this, that people thrive on being given the freedom to operate to the top of their license. And people do wonderfully well. It's amazing how we create structures that make it difficult for people to be able to come forward and show their leadership potential. And I think that the next question that many people have raised and spoken about is the fact that there's a lot of conversation about the transactions of how this model was created. So they have heard from you in many places. I mean, it's been quoted in so many journals about the work you've done. It is absolutely outstanding. But clearly, as you mentioned, the start of the conversation and perhaps the middle of the conversation and the end of the conversation is the conversation with the staff who were going to change and what it meant. So putting aside the transactional part of it, how did you approach the build-up of the emotions, the build-up of the culture within the new organization, which was owned by people, so that they could realize it was different from what it was yesterday to what it will be today?
Yeah, so we we started the conversation with them. They could all see that the partner numbers were dwindling, and that was causing a lot of uncertainty within the staff, because it's their livelihoods, it's their futures. And if they see that the owners of the business are sort of decreasing in number, it creates a lot of anxiety, a lot of uncertainty. So that's where we started the conversation with the staff. We said, we know you're all worried, we know you're all anxious, but actually we've thought of some options. Okay. And the options that we had, we said, look, we could either turn around and say, hand in the notice on the contract and leave it in the lap of the gods. We've in Somerset, we've got an organisation called Symphony Healthcare Services that run a number of different practices. And we said, well, we could approach them and see if they want to take over the running of the practice. They're also a limited company, but they're 40 odd miles away in Yeovil from Minehead. And we said, well, we could do this. And we said, happy to discuss all the options with you, but what would you like us to do? And they were pretty much unanimous as, the conversation progressed. They said, we want to stay local and we'd like to own this. There were anxieties about personal liabilities, but we managed to put those to bed, saying, the conversation we had with the lawyers, we said, there aren't any. And so we went through that process, and it was a similar process talking to the management team who have become the directors, so that the directors aren't GPs. There's only one GP director, which is really important. So it's an evolving conversation, and it's also having that complete open door where people feel free to ask questions at any time. It's not just a case of we're having this one staff meeting. If you haven't thought of your question, then put it to bed until the next staff meeting. So it's that ongoing discussion. And there was a sense of disbelief that this was, actually going to happen. And then when it did happen, those of us that have been driving the process through fell in a big heap to sort of recover. But actually the staff then sat up and went, oh, hang on, we sort of own this business. And it wasn't a big bang change for how people work, but we then started to sort of make it real for people by empowering them to make decisions. And, there was another example where our reception lead turned around and said, we had something from our infection control that was a detailed checklist that was supposed to be done every day in reception. And it was like, well, people aren't wearing masks, they're not using hand wash anymore and all this sort of stuff. They're getting back to normal. We said, do we need this checklist? And I said, well, why are you asking me? Why don't you go and ask our infection control nurse who leads on that to say, is this necessary? As opposed to that. And you could see the light bulb go on in her head. And she went, I don't need to check it with you because you're a GP anymore. I can just get on with this and we can sort this out ourselves. And it's those little bits that you go, you've got it now. And actually you can now go on and implement change independent of running everything past a GP.
Fascinating. How fascinating. I absolutely love the example of, I don't have to ask you anymore. Actually, I'm accountable for it. Such a turning point in the way one thinks to recognize it is mine. I have to make the difference. And it was really interesting because you spoke about Yeovil, and it was one of the questions that has popped up around Yeovil providing this large Symphony primary care services in the area you're in. I mean, it's not next door, but it's fairly close, and same geography, same ICS. How did this impact the relationship with Symphony? Because Somerset seems to be pretty blessed with a number of different models of primary care delivery.
Yeah, so it's, I know the guys that run Symphony very well, and they do a fantastic job, but they have a different purpose. They were set up to essentially stabilise a lot of practices in the Yeovil area, and they have then since become almost the go-to organisation to step in and pick up failing practices when they've either got financial issues or they've lost all their workforce, or they've got management problems or anything like that. But each time they do that, it costs the system an awful lot of money, because you are talking about, practices with issues that they've got to essentially go in and turn around. And we are very clear we didn't want that. We didn't think we needed that turnaround process. So they were actually, if anything, probably quite relieved that we weren't queuing up at their door, providing them with yet another practice. And also, as their medical director has told me, he said it's not healthy to have one organisation running the majority of practices in Somerset. You do need that variety. You do need that sense where you can bounce ideas off each other. And just because we've done this model doesn't mean this model will suit everyone. We've got a functional team. We've got a functional practice. If you have a practice that has got management issues, has got financial issues, who haven't got any clinicians to provide a service, changing your model isn't going to fix that. Okay. But actually, if you've got a good culture to start with, this just builds on that and actually empowers all the staff and makes them feel more part of the business. And the bonus from my perspective is that we get de-risked and you don't end up with a shrinking number of partners holding ever bigger and bigger risk that essentially forces people to leave. And we would have lost a number of GPs had we stayed as a partnership because they weren't willing to stay on holding that level of risk.
I think it's very encouraging to hear from you the story around the transformation happening without failure, because you're right. A number of unique models in primary care have evolved as a consequence of certain partnerships failing, practices finding it difficult, whether it be recruitment, financial, quality, many of those issues that came through. But yours was a different story. It was a game changer. It was a transformation that was aided as a consequence of people coming together to create a different model that formed the resilience that was missing in general practice now, but also brought forth the recognition that actually failure is not the necessary change required. It can be done with people wanting to make that difference because they've seen changes in the way primary care is operating. And I think that does lead on to the question of, there are some phenomenal successful things you've told us about this creation. And what was it that was the challenge? So what were the pitfalls when many people look at your amazing story and want to jump into this to say, that's my answer and my Messiah is going to be Ed's story? So what would you tell them are the top 3 things they need to look out for? And what did you do when those things came out so that there is learning from those?
Yeah, so I think one of the key things is making sure that you've got a good management team. And getting the buy-in of the management team was really critical. It would have been very easy for us to sit there and say, well, actually, we'll make all the GPs the directors of this, that, and the other, and not really change the power dynamic, I think is probably the best way to put it. So I think I was very clear at the start that we had to have the directors coming from the teams that were, so essentially we've got a finance director, we've got a managing director who's the ex-practice manager, we've got a nursing director, we've got myself as the medical director. And I think this was my experience in the CCG, we mirrored this, whereas I was looking at other limited company models and the directors were all the GPs. I thought that doesn't really change how you deliver how you run your business. You have got to sort of demonstrate that you're willing to empower staff. Now it's difficult for a lot of the GPs to step back from that. So, I still occasionally get an email from an ex-partner saying, we need to have a conversation between the 3 or the 4 of us. It's like, no, we don't, because actually you are now just a salaried doctor. But I'll still listen to your views and I'll still meet up with you and we'll still have the conversation. But I think that is a potential pitfall if you still stick with looking to the GPs to hold on to the responsibility. you're not really going to change your culture. I think one of the other issues is making sure you've got someone who is sufficiently clued up, as particularly a finance director, to keep a tight rein on finances, because it's not like having a partnership where you have big bills, which are the tax bills that come twice a year. You know, you've got to then make sure that the income you're getting on a monthly basis is matching your outgoings. And, you know, we had to turn around and say, well, we can't freely spend money on getting additional locums, because actually everyone's entitled to their salary. And historically, where the partners would have said, we'll just take a cut in our drawings, you now have to budget a lot more tightly. So it does give us, you know, as GPs, we earn less than we would have done as partners, but actually we have got more financial stability as a result. So, you know, but it does require very tight budgeting. And, you know, we've had issues with missing payments from the ICB that we've had to challenge, but we've had to challenge them because we've had to say, look, you know, you're affecting our business model, our business delivery, if you're not paying us the money that's due. And it does then change the commissioner's view, that they turn around and say, well, actually, we do need to address this quickly, because this is going to be a reduction in service as a result. So that's also really, really critical. And I think the other bit is the HR processes. I mean, I know a lot of people, when I spoke to them in Somerset, were getting quite tied up in knots about what if your staff didn't want to transfer across to the new company. And it's like, well, it is a fairly straightforward TUPE process from one company to another. They are going on the same terms and conditions. You're not changing anything, so it's suitable alternative employment. If they don't want to transfer over, well, they resign. But you're giving them an option. So you're not looking to make people redundant and have lots of redundancy payouts, which I think a lot of partners were fearful that pushing forward this level of change could expose them to. And, you know, we haven't had any members of staff leave because of that transition. We have obviously had turnover of staff, but that's for other reasons. But, you know, it's no one has turned around and said, well, I don't want to become a shareholder in the organisation, therefore I'm going to go as a result. And actually, if anything, it's attracted more people in. So historically, we had, you know, it was difficult to recruit admin staff and receptionists from the local population. Last time we went out to advert for a couple of receptionists, we were inundated with applicants because people were going, oh, this is really interesting. I'm going to join because that feels more like part of the team. So it has changed things.
Oh, fascinating! How very, very fascinating, and it's really good to hear about the way the engagement score seems to be improving on the practice. I mean, mere indicators like being inundated with people applying for roles is fascinating, because it's not what happens in general practice. Generally, it's a difficult area to recruit to. There is this perception that a receptionist is like any other receptionist, and they're not. They're actually pretty specialists, and many of them are care navigators. They're able to stream people in the right place very quickly and improve the satisfaction. And I think that does lead on to the question. The reason many of us create these special purpose vehicles, different models of delivery, is to improve care. And you can see from the engagement of staff improving is immediately an indicator. It's a proxy indicator of care improvement. Have you had any measures in terms of patient outcome surveys that demonstrate, is there a perceptible difference in how they found care now delivered in a newer ownership model from every staff member versus the previous model where it was just the GP partners, as you were talking about?
Yeah, we haven't. I think it's still early days to reap any rewards. You know, we're only sort of just over 5 months into the process, and I don't think any of our clinical staff have changed how they deliver their care. I think what it has done is this has more been about preempting what could have been a failing practice in a year or two's time when we ran out of partners and couldn't function. And I think, but what we've probably seen more of is people being more open, and clinicians particularly being more open with each other about the stresses of the job and not hiding their stress from other people, and, you know, not sort of expecting the partners to, manage their own stress because they're in charge and, they should be taking the burden of stress off everyone else. And general practice is a very challenging place to work at the moment, full stop. We only need to read the media headlines that there is decreasing, satisfaction with how general practice is run and delivered. We were struggling to, if we're going to look at our other local practices, to perform at a similar level to them. But we have probably, more importantly, we've levelled off any deterioration in service as opposed to, seeing a continued reduction in service. And I think we're hoping that we can start to improve things. We're starting to build up on our clinical team and use less in the way of locums now. But I think what it's also allowed us to have, it's allowed us to have an honest discussion with our patient groups to say, this is the income we get, this is where we spend it, this is what you get for that level of money. If you have issue with with a level of service and you want us to provide more, you shouldn't be coming to us. You should be going to our commissioner to say, please, can you fund them more so they can do X, Y, and Z? And I think that's the conversation changer with patients, that it's now not about, we're not doing it because we don't want to. It's about saying we're not doing it because we haven't got the funding, we haven't got the staff to do it. So it does change that conversation. And I think it is about being honest with patients, being honest with staff, and just saying, well, actually, let's do the best that we can for with the resources that we've got.
I think the point you raised about honesty is such an important one, because our patients are very intelligent, our residents are very intelligent, and very often there is waste in our system that doesn't need to be there. And I think they are the right people who are able to point out, to say, why are you doing that? You can change it and do something completely different. Also, it was very, very encouraging. I mean, you're spot on when you say 5 months is too early to be able to say, has this made an impact? And I think you're right. Over 2 years, you'll get a feel of how far the journey has taken you in improving patient care. But the early indicators of being able to say, we have leveled off and we are not seeing the same deterioration, is actually very encouraging. It was really nice to hear this, because for all the change you have made, if a patient who's ringing your practice can now say, I have the same access I have elsewhere rather than the previous access, which was less, that's fabulous for every dad or mum or kid or grandmom who's trying to do something for their children, loved ones, or for themselves, and also reduces the burden of people going to secondary care unnecessarily, which is a system waste, isn't it? And that resource recycled allows for things to happen, more things to happen in primary care, so you're able to deliver even more services, exactly as you were saying, in the longer term. And that's phenomenal. I think it does lead to the rather unique question that seems to plague primary care. Primary care, for the much as it's one of the most loved parts of NHS, is plagued by the legal services. I mean, GMS contract, APMS contract, PMS contract, you name it. They've got different kinds, different conditions. From a resident's perspective, there is a GP. I go and see my practice. That's what I go for. How did this uniquely different model work through the nuances of the legal challenges that primary care seems to plague? And how did you work that through? I know you spoke eloquently about wanting support to get legal resources in to set out the framework. But how did you work through the myriad of things so that NHS England was able to sign up to a contract that was now held in a company owned by multiple people, which were not always doctors, and actually the receptionist was one of the directors?
Yeah, so I think we had really good support from the legal team. So there's legal company we use was a group called Postlethwaite's, who have set up a significant number of the employee-owned trusts in the UK. But they'd never done it with a GP surgery before. So they were learning as much as we were, but they really understood the nuances and the process of setting up an employee-owned trust. So, they've done it with architects, they've done it with, lawyers, etc. And I think what's been really interesting is when you look around, if we look outside of medicine to the other professional bodies, so vets, architects, lawyers, etc., there's a significant number of them who are moving away from partnerships to employee-owned trusts. And bizarrely enough, the architect that sorted out our extension that we'd had done at the surgery became an employee-owned trust on the same day that we did, which was just bizarre, but there you go. But actually, they've got huge amount of experience in that. And yes, there are nuances about, so we did talk about having a patient as a trustee that we couldn't do. So we said, they can't be a formal trustee. So rather than say, no, you can't sit on our board, we'll let you sit on our board. You just don't technically have that trustee name. And there's another little nuance where, the GMS contract dictates that at least one share needs to be owned by a GP. So we said, okay, we'll have one share owned by the medical director, but actually it's a non-voting share. It's a different sort of share that doesn't actually allow the medical director to make any dividend or make him any different to anyone else in the company, but it's just sort of there, and it's 1% of the other 99 shares are held in trust. So it was looking at these obstacles and going, okay, yes, that's potentially an obstacle, but let's work around it. Let's keep our focus on the goal is to make essentially every employee equal, and to have increased patient involvement in the running of the business. Let's not take our eye off that ball, but when these hurdles come into place, you navigate a way around them. And you embed that in your company documentation to make sure that it is there and it's fixed, so that it can't be amended at a later date that could sort of disempower people.
How interesting. And I think it's a rather interesting journey to try and go through this minefield of rules we put in place, which you've actually just myth-busted in a way to say you don't have to have a doctor to run that service. Of course, you need doctors as part of the clinical team to deliver the care, but they don't actually have to run the business for it to be a good service to the local residents. And I think that is such a crucial part. And I recall having a conversation with the directors at Nuka in Alaska. And all the directors running the hospital are local residents. They are not doctors and nurses, and they decide on what's right. And speaking to the managing director, and she said, oh, yes, we've got a department who does the paperwork for the government, so they're all happy. But we get on in making sure our local residents get what they want for their care. And the outcome has been they have a 30% reduction in A&E attendances from the time they've taken it over. And what more do you want as evidence to show care can work in different ways? And I think it's amazing to hear what you've just said. And I absolutely love the thing around make every employee equal, because actually the role each of those employees in the practice play is phenomenal. One of the things that does pop out, though, with becoming a director in a company, and I have the dubious pleasure of being a director in about 5 different companies. So you get this beautiful letter from Companies House telling you how much they love you and what your responsibilities in the world are. And what process did the employees and the staff go through to recognize their fiduciary responsibilities now as both shareholders and subsequently as directors? Because it is all right to say, as a finance director, I am the right person to do the job. And there is no doubt, actually, I've seen some practice managers who would beat the pants off of the system in getting it right to make sure the practice was robust. But there is a fiduciary responsibility that comes from becoming a director in a company, which means there is a personal liability element. How does that get squared, and how do people get supported in that environment so they don't feel left alone should something go awry?
So this is where going back to having a project manager to manage the process was really important. So they could then have a one-to-one with the directors, they could also, and also the trustees as well, because we have to bear in mind that the trustees is quite a unique role for them. And we're still doing some trustee development, as we speak. But they then have the dedicated time to sit down with them and go through what the responsibilities are, what the liabilities are, and also with the legal team, so they could link them with the right people in the legal team. Say, you've got this specific concern, let's get it addressed. But again, that's part of bringing all the staff along with you, and actually, rather than saying you're going to sit and have a lecture, we're going to tell you what your liabilities are, et cetera, et cetera, et cetera. Some people are going to shrug them off and go, yeah, that doesn't bother me. Some are going to become really anxious and, internalize them. And it's about giving those people the right opportunities to explore those and put those to bed with the legal team. So having the project manager, that was part of her role, was to link with the legal team and certain members of staff to make sure that everyone was happy going through the process and content with what they were signing up to.
How helpful. And I'm assuming you've got the company liability for directors so that they are all protected in this process.
Yes. Yeah, absolutely. Yeah. So, we've got the insurance that backs us up to make sure that there's no personal liability. And we were talking about in one of the first conversations we had as the proposed directors with Postlethwaite, the company, was saying, well, what happens when it goes wrong? Have there ever been any sort of trustees who have been sued? And they were sort of saying, well, there have. But then the one thing that came to mind was the I think it was the chairman of Road Chef who, took about 8 million quid out of Road Chef into his personal bank account. And it's like, well, okay, you do something like that, you deserve to be prosecuted. And it was, they made it quite clear that, if you do something illegal, you'll be prosecuted. That's quite simple. But if you do the best you possibly can, your liabilities sort of fall away.
Indeed. And I think that's a really, really good point. And I think it does raise another question, Ed, and this is the question of where is primary care going in the future? So you're spot on when you say, for a practice, this seems like a fabulous model to explore for people where there is the buy-in from the staff, where people want to progress on to create something different for the local residents. But primary care is moving towards the development of primary care networks. And many of those networks are employing staff within those networks, and which are still very traditional companies. Some of them have got staff employed through practices. Some of them have staff employed directly as an organization if the PCN is incorporated as an organization. And sometimes it is through a secondary care trust, so they're funded and then they employ the trust. So the different models around the country. And I think the question that comes back is, how do you square the principle of equity when in your network you will have some staff members employed through your practice, and it is an employee-owned practice, it's a shareholder practice, and those staff have a level of ownership that puts them in the position of buy-in, that says it's mine, I have to care for it, versus other staff who come and do some sessions there from employed in other practice or in the PCN. So how do you square that principle of equity when working through this mixed group of staff?
Yeah, so we do have quite a few PCN staff that come and work in the building. I think the key bit is that we like to make them feel part of the team. So albeit they're not employed by us, we still have a great team ethos. So they're included in, how we work as a team, whatever we do with any social activities, et cetera, et cetera. So they have their own, they have their own pigeonhole and things like that. But there's those little bits that make them feel that they're walking into a building where they're valued as a team member and they're not just parachuting in and leaving. And I think that doesn't take much to do. That doesn't cost us anything as a business. It doesn't, it doesn't sort of, change how we function. But but again, this is why it's worked for us, because you've had that good foundation as a team to start with, and actually, team members. It's, I think if you were playing professional football, you could have someone from another club parachuted in for a season. You'd still make them feel part of a team, because if you didn't, you wouldn't function playing football together. So it's exactly the same principle in that respect, is that, you work on that team dynamic to welcome these people on board. And, and just because they're employed by someone else doesn't mean that they can't benefit from, the atmosphere that we culture within the surgery and within the practice. If you treat them like an outsider, you're never going to get the best out of them, and your patients aren't going to get the best out of them, because they're not going to feel that they're really sort of part of your team, and that those patients are their patients, as it were. So
true. So true. Very wise words. I mean, patients being everyone's patients, so crucial in the system we work in. And I think one of the principles that people have raised, and this was a question I should have posed much earlier when we were talking about the legal ramifications, but it kind of seems to fit in better here now when we talk through it, is one of the principles of setting up the GP practice and the way the partnership is set up currently is, should something untoward happen, death of the GP, closure of a practice, movement of partners, territorial movement in terms of the geographies and the way it's laid out, it allows for patient care to continue by dispersing the lists, by closure of the practice, by moving the legal requirement to other practices, or through procurement of a new practice. Given this is a rather unique way of delivering, do you have a view, Ed, on how that closure could be achieved here, vis-a-vis a closure in a more traditional sense that often happens in GP practice, to continue patients to receive secure services?
So I think what's been, and I'll draw on my experience from working with the CCG, is that closing a practice is possibly one of the worst things you can do as a commissioner, and gives you one of the worst headaches imaginable. Dispersing patients to other practices is fraught with risk about destabilizing them, etc. And going out to re-procure a practice often fails, because there aren't providers out there who are willing to step in to do that. So, having, if things went horribly wrong, and the trustees decided they no longer wanted to continue running the business, we could serve notice on our contract, and then it would be the commissioner to decide what to do next. But, fundamentally, if things started to fail, quality started to go down the plug hole, we'd lost a load of clinical staff, couldn't provide the services that we were supposed to do, then at least you've then got a business model, similar to a foundation trust model. If you have a failing hospital, you don't just suddenly go and say, well, okay, we're going to look for a new provider to parachute in and run it better. I think they tried that somewhere up in Cambridge away and didn't particularly work very well. But, the commissioner can then work with that business model, whoever's left, to say, actually, we will step in and try and help things improve, which is a far better commissioner-provider relationship than the commissioner just purely sitting back and saying, okay, I hold the contract, you do as you're told, and then I'll take it off you if it doesn't work and give it to someone else. Because fundamentally, there's no one else to give it to in the current climate. And I think also, dispersing patients and closing lists yes, it does cause a lot of instability, and I think certainly in our neck of the woods it would have a domino effect on a lot of other practices falling over. So what it does do is it creates people who the commissioner can go to and have a rational conversation with, who aren't worried about their own personal liabilities, losing their house, losing everything that they own because it gets sucked into the business. But they can have a rational conversation with what will be some very stressed directors about how to improve things, rather than actually looking for a completely new business entity to run them, to run the services. So it still create something where patients can go to, can have their services, but it also creates a model that commissioners can work with, and systems and other providers. So a foundation trust could work with us, and because you're not there to make profit for individual partners, you're there to serve the community and make sure that your staff are able to do the best job they possibly can.
It's been one of these most amazing hours that's been flying by. So before we conclude today, any words of wisdom for people who would like to say, my mantra for tomorrow's primary care is ED4? What do you like to tell them?
I think the key thing is that, it isn't all doom and gloom. There will be a future for primary care. I can't see general practice disappearing into the ether. And, I think what you have to do is you have to be open to the fact that things will change in future, whether we go the same way the dentist, but actually be nimble, create something that allows you to change, and actually focus on yourself, because fundamentally, if you're not happy in your own skin, you can't provide a good service to your patients.
What a phenomenal way to end. And I think my mantra for taking away from today was your statement saying, make every employee equal. And what's fascinating, Ed, is having been a doctor for over 32 years now, it's been one of those things that many of us have wanted to achieve, because we know genuinely care improves when we work as a team with everyone, from the cleaners to the receptionists to the people getting the files, all the way to the clinicians who together create this team. And today, your presentation brought home the fact that you didn't have to be this huge, big organization to create that transformation, but the nimbleness with which primary care can deliver this and make a difference to the outcome for local residents. And that'll be something that'll ring true for me for the remainder of this month, and if not, for the rest of the time I do this. So thank you so much for an absolutely phenomenal hour, packed with so many crucial, important nuggets to take away. So today you've been really inspirational, Ed, and thank you for that. I'd also like to take a moment to thank Sarah, Farana, who have in the background made these webinar series possible, because they sit in the background and make it work like absolute water rippling through a stream. And I kid you not, technology is not my forte. So I'm so grateful I have people like that supporting me to make sure we are a partnership. And really, the reason why we put in this time, the reason why this works, the reason why this is so lively is because 350 of you have, over the last 18 months, been registering regularly for these webinars, sharing with us our journey of learning and understanding primary care so that together we build a better future. Thank you for being with us on this journey, because it would not be possible without your partnership to make this happen. Sarah would have posted the feedback completion forms in the chat session, so please do use them so we know how we would continue to improve these sessions and make them even more meaningful to you in the new year. And for all of you, wishing you loads and loads of happiness over this festive season, and looking forward to seeing you all with the new series of webinars on 2023. Have a great evening.